Hi, I'm Dr. Joseph Elliott. I'm a second year cardiology fellow at Canton Medical Education Foundation, affiliated with Neomed University, located at Altman Hospital in Canton, Ohio. Today I'll present a case of clot in transit involving a thrombus entrapped in a PFO that required surgical embolectomy. Acute massive PE is a catastrophic and potentially life-threatening event. Provoked lower extremity DVT can lead to propagation of thrombus into the right side of the heart, causing massive pulmonary emboli and right heart strain with the potential for early hemodynamic collapse. Paradoxical embolism is a rare occurrence, but can occur in the setting of right to left shunts, predisposing susceptible patients to left-sided arterial embolization. We present a case of postoperative lower extremity DVT with propagation resulting in clot in transit, causing massive pulmonary embolism and paradoxical intracardiac embolism through a PFO as seen on TEE. A 62-year-old Caucasian male presented to the emergency department for complaints of chest pain and shortness of breath following a carotid endarterectomy 11 days prior. Vascular ultrasound revealed an acute provoked lower extremity DVT. Further workup with CT angiography of the chest revealed large bilateral pulmonary emboli involving both main pulmonary arteries with extension into all three lobar branches bilaterally and distally into the segmental branches. A transthoracic echocardiogram showed highly mobile echo densities involving both atrium with apparent extension into the mitral valve apparatus without any other evidence of right heart strain. The patient subsequently underwent transesophageal echocardiogram that confirmed a large, highly mobile echo density traversing a PFO consistent with thrombus. There was further extension into the right ventricular outflow tract, with the left side of the heart showing filamentous extension across the mitral valve apparatus. Given the massive thrombus burden involving bilateral pulmonary arteries and intracardiac thrombus across the PFO, a comprehensive heart and lung team approach evaluated potential treatment strategies. The decision was made to proceed with surgical embolectomy and PFO closure, given the high risk for embolization and potential hemodynamic compromise. This is a 4-chamber view showing the extensive nature of the thrombus. Here you can see the clot entrapped within the PFO. In addition, on the right side of the heart, you can see that the thrombus traverses the tricuspid valve. And on the left side of the heart, you can see that there's extensive clot in the left atrium with extension into the mitral valve apparatus, as well as left ventricle. Massive pulmonary emboli are particularly common following surgery. Treatment strategies consist of cardiopulmonary support and anticoagulation. Immediate anticoagulation for the prevention of further thrombus and recurrence of pulmonary emboli is pertinent. Early reperfusion of the primary pulmonary vasculature remains a critical factor for treating massive PE that result in hemodynamic instability and subsequent cardiopulmonary collapse. Systemic thrombolysis is typically a viable option in patients without contraindications. In this case, using systemic TPA or catheter-directed therapy were not viable options, considering the paradoxical embolism in transit. Further thrombolysis of this clot trapped within the PFO may have induced fragmentation and subsequent left-sided embolization. Surgical embolectomy is indicated for patients with massive thrombus burden involving the main pulmonary arteries that have contraindications to TPA or catheter-assisted embolectomy and concern for hemodynamic compromise. It's also an effective treatment option in circumstances of paradoxical intracardiac thrombus whom are at high risk for left-sided embolization with further thrombolysis.